diabetic macular edema. The global disease burden of diabetes is on the increase, and so are the complications of diabetes and diabetic retinopathy, including diabetic macular edema. In Australia, we have the same problem. From 1990 to 2012, the burden of diabetes has doubled, and it's estimated that about 72,000 people in Australia have diabetic macular edema, of which 60% of them have visual loss. We've been talking a lot about laser, and yes, we know the blood-retinal barrier breaks down and there's leakage and there's swelling and there is fluid in the macula and the vision goes down. Yes, we know that laser has an important place to play, but also it's clear that macular laser does not cause or does not help the vision to come back. It maintains it where it is, and it must be done early. A lot of recent focus, of course, is on the upregulation of VEGF, and especially VEGF-A, which then causes the blood-retinal barrier to break down, and hence the slight change in thinking from just laser to the use of anti-VEGFs to reduce the upregulation of VEGF in this disease, not only in diabetic retinopathy but also in diabetic macular edema. Now, the major culprit, the major player, of course, is VEGF-A, and we know that the levels of VEGF-A actually are higher levels of VEGF-A are seen even before active disease develops. So there is a lag between what happens biochemically and what happens on the OCT and reduction in vision. We also have been looking at other isoforms of VEGF, including placental growth factor, and know that all these things do play a role in diabetic macular edema. So in the anti-VEGF era, we are really looking at not only stopping visual loss, but reversing visual loss, improving vision, and therefore improving the quality of life. That's why we are all trying different options, different drugs to see that we can reverse the ravages of diabetic macular edema. Now, what I'm going to talk about, I can't help but show you the studies, so somehow they have to come in. But all the studies, whether they were the studies on ranibizumab, did show similar patterns to the outcomes in wet macular degeneration. In fact, many of the lessons that we are talking of today are the lessons that we've learned from macular degeneration. Loading dose increase, and we say that if you keep on injecting every month in this case, you can maintain the visual improvement in these study patients for up to 3 years. But we see only about 35% to 45% of patients actually have that improvement that these studies talk about. Another thing they don't talk about very much are the side effects, not only the ocular side effects, but also the systemic adverse effects, including serious things like myocardial infarction, stroke, and death. So injecting in this subgroup of patients is not without its complications. Coming on to aflibercept, again, the VIVID and VISTA studies, whether the aflibercept is given at 1 monthly or 2 monthly intervals, you find that here there were 5 loading doses, and then after that either 2 monthly or 1 monthly injections, and you find that the results are actually quite similar. So are the side effects. The side effects are more in patients who are injected than patients who are not, and I'm talking of the serious side effects. So it's fine, all this works. But if you look at the life of a diabetic, they've got to go to their GP, they've got to go to the endocrinologist, then the nephrologist, then the podiatrist, and also the ophthalmologist say, you come and I'll give you an injection every month. I think it makes sense that we look at the same thing that we did in macular degeneration to see if we can reduce the burden of injections, which will reduce the cost and also reduce the complexities that are part and parcel of a diabetic's life. And at the same time, to maintain that outcome of improved vision and a good functional outcome. So we also try to identify in our patients whether any of these markers that are being talked about are something that can predict visual improvement. So what we've done is to investigate a treat and extend regimen in patients with diabetic macular edema using intravitreal aflibercept. Basically, patients who are naive to treatment or near naive to treatment were selected, and what I'm going to present to you are just the interim results because the study is not yet over, but it's an open-label, prospective, multicentric study in Tasmania. All patients have received 5 loading doses, and then after that, depending on the criteria, either the gap between injections is increased at 2 weekly intervals, and if they start deteriorating, basically they come back. So 5 letters decrease or persistent macular edema was enough of a trigger to bring the patients back. In this study, the protocol did not allow us to go beyond 12 weeks. Simply, the central macular thickness reduces, and this is seen in the RISE and RIDE and VISTA and all these studies, that the first injection does cause, in naive patients, a fair amount of the initial effect, but then after that, following the 5th and 6th injection, things pan out. Now, this is a graph which is on 1 letter increase, so just the increase, not the actual vision, and you find that after the initial 5 doses, there could be a decrease, and again, this is only the first 8 to 9 months, but basically there is an improvement even with treat and extend. But this is the interesting graph where you see after the first loading doses where everything is close together, after that it spreads out. So you've got a subgroup of patients who respond well and can do very well with a treat and extend regimen, and you've got patients up to 70 days between injections. No new signals in terms of side effects, and here are some examples. What one sees is a patient with, this has got all the components that have been shown earlier. There's also disruption of the layer, subretinal fluid, intraretinal, inner retinal, outer retinal, and what we find is that with treatment after loading, vision becomes better. And you find that the outer retinal fluid tends to stay on a bit longer, but is still compatible with good vision. So really the question comes, do we really need to dry these patients out completely or not? I don't think we know the answer as yet. Here's the patient's other eye. Again, 6/9, you can see some chronic changes here in the cysts that were talked about, but they do disappear with time. So maybe they're just lipoprotein, maybe just proteins. That's his other eye on 2 monthly injections with a visual acuity of 6/6. Another type 1 diabetic with a cyst, nothing else inside, responded quickly to loading and then maintains a vision of 6/7.5 despite some pockets of fluid. Watch this. We are all clear about the fluid there, but watch the photoreceptor layer and the disruption there. You find that recovers quickly, and even though there is fluid, the vision has improved. So it all fits in with what is logical. If the photoreceptor layer is not involved, vision is good. And you might have pockets of fluid still remaining, and the vision actually does recover. You can see that there are changes. Now, I don't know what will happen in the long term, but we are keeping a watch on this to see whether it's compatible with good vision in the long term, and it seems to be 6/7.5 without any metamorphopsia. We haven't been able to, there have been a lot of this thing from the Italian group about trying to find predictors, but we haven't been able to find anything besides thickness, retinal thickness, and great increased central macular thickness as a very definite predictor of what's going on. But none of the other things seem to be very consistent and reproducible. In 2 years' time, we'll be looking at how the vision is maintained with a treat and extend regimen. We're also going to be obviously looking at the number of injections and the frequency, and also trying to see if any of these patients fall into your recalcitrant category or escape with treatment. So very briefly, the use of intravitreal aflibercept is very well tolerated for the management of DME. Most of the improvement is apparent, like in all other studies, just after the loading dose. The OCT changes may persist, and even though there is fluid, it does not mean that one can't have good visual recovery. And I think it's possible to get comparable results to a fixed dosing regimen using treat and extend. Remember, DME is a complex condition. It's not like macular degeneration, although we've learned most of our lessons from macular degeneration. And I think we really need to remember that you can't treat diabetic macular edema in isolation just with anti-VEGF agents, and that you really got to look at it at a multidisciplinary thing, not only systemically, but also locally using different drugs depending on and laser, depending on what is going on. So I think this is the next sort of frontier where a lot of algorithms will come out, a lot of new things will come out, but we'd be able to do, I think, the wonders that we have been able to do with macular degeneration. Thank you.
Thank you very much. I think we come to the end of this course, and thank you all for your participation.